So let's go on straight away. And we know the classification of international classification of sleep disorders, which is basically grouping these two categories, which I'm supposed to be addressing. And we know that in India, about a good 30%, which is 100 people walking in with sleep complaints, out of them 30% are going to be insomnic, and more so they're going to have many comorbidities. So another study, which is done by a neurologist at NIMHANS, one of my students, has a rule of 18, which is 18% in South India had insomnia, which would mean somewhat similar to Hyderabad population. And of these 18%, it's easy to remember, 18% had difficulty initiating sleep, 18% had difficulty maintaining sleep, and just make it 8%, 8% had an early morning awakening. And of course, there was associated significant psychiatric comorbidity of depression and anxiety. So you're going to get a lot of patients coming in from psychiatry, and you need to work together. And this is, of course, more often in females. So what's insomnia? And we know insomnia is just a condition where you have an adequate opportunity to sleep. That's the first requirement. You should have got the 7 to 8 hours to sleep. Despite that, you are not going to be able to initiate sleep. You're not going to be able to maintain sleep, or you're going to get up early. And this is going to result in consequences to the next wake hours of yours. So it is not a night disorder. It is a 24/7 disorder, insomnia. Now, for the ease of understanding, chronic insomnia is something which we need to know as, teen tigada, kam begada, which is the rule of three nights a week for more than 3 months. So if you are not able to do any of those, initiate sleep, maintain sleep, or get up early, you have chronic insomnia. And of course, short-term insomnia is anything less than that, which is less than 3 months. So really, you need to remember this 3-month rule. So as I told you, you need to have one or more of the following: initiating sleep, maintaining or getting up, or one or more of the daytime consequences. So you need to have either fatigue, attention, concentration impairment, impairment of social functioning. This is often overlooked. People are irritable, people are having road rage, people may be actually insomniac, maybe, just disturbed behaviorally. They have mood disturbances, irritability, daytime sleepiness, behavioral problems, and general dissatisfaction with sleep. So you need to have one of that and one of this. And of course, you need to have the 3-month criteria. Now, when I was training as a resident in neurology, we were told that you need to divide them into primary and secondary. Primary is where it's only insomnia, and secondary where it's associated with other disorders. That dichotomy has been dissolved. So you really don't need to classify your patients as primary and secondary, and you really don't need to have a non-restorative sleep as one of the criteria. So this is just to show you what a typical hypnogram is going to look like. Now, normally we don't do PSG in insomnia, but we should know when we have to do PSG in insomnia. So here's a patient who is in one of our studies, which is ICMR funded study for a herbal compound, Ayush product for insomnia. So you can see a prolonged vaso. Can anybody in the hall tell me what is the normal vaso and what is the normal sleep latency? How much time does a normal adult take to get to sleep? Okay, under 15 minutes, and definitely not more than half an hour. And in children, 5 minutes. So less than 5 minutes, the child should be asleep. So you can see here the patient is awake for almost 2 hours. So he has a delayed or difficulty initiating sleep. And then in sleep, you can see the number of times he's getting up. So there is an increased vaso. What is the normal amount of vaso which is allowed? Which is wake after sleep onset. All of us wake after sleep onset, isn't it? Either to go to the washroom or, to attend a call. But what's the normal amount of time which is allowed? Vaso? Within half an hour, you should not have a vaso which is more than half an hour. So, as I told you, insomnia impacts us, and the impact is in almost everything. It increases the chance of psychiatric disorders, cognitive impairment, huge role in memory, higher absenteeism from work, reduced quality of life, higher healthcare costs, and increased accident risks. And of course, there's interesting research to say that it ups the amount of cancer, hypertension, diabetes, obesity, and metabolic syndrome. So what are the risk factors? Who of those 100 patients or those 30 is going to have an increased risk. So there are environmental risk factors, especially if your sleep environment is not conducive to optimum sleep, whether it's the temperature, whether it's the light, whether it's, the mattress, whether you have a conflicted bed partner who's fighting with you and you're anxious about it, behavioral, excessive worry about sleep. Some people are doing this vigorous exercise before sleep, which is definitely not indicated. And pre-bedtime activities, particularly in this generation of computers and what have you, the iPads, etc. Physiological, like changes in brain metabolism across age, and pharmacological. Believe me, a lot of our patients, particularly the middle to age elderly, are on medications which impair their chance of sleeping, whether it's antihypertensives, steroids, decongestants, even nasal decongestants and nasal steroids, antihistaminics, and antidepressants. So basically, you need to remember the BCP model: behavioral, cognitive, and physiological, because your intervention is going to delve into this. So behavioral would be, having deranged behaviors prior to sleep. Cognitive would be having difficult thoughts and feelings about sleep. And physiological would be a dysfunctional brain region. So as I told you, dysfunctional cognition, we see a lot of women with this: worry over sleep loss, rumination of the consequences, unrealistic expectations of sleep, amplifications of sleep issues. Some people are perpetually in the hyper-aroused state. They don't have a sleep mode. So there is this emotional, cognitive, and physiological hyper-arousal, which is so common even in the young. So young person presenting to us with insomnia has more or less this kind of problem causing the insomnia. And then, of course, maladaptive habits, which I told you about: excessive time in bed, daytime napping. Some of us, are into this. So basically, one needs to try to find out in each patient the 3 Ps, which is the traditional Spielman model. And this model has to be remembered by all. One is the predisposing factors, as you can see here, and which is in the yellow, and then is the precipitating factor and the perpetuating factor, which is in red. So acute insomnics, all of us have had insomnia, around exams or around a tough situation in family life or whatever. So we do have acute insomnia, but we do not have the perpetuating factor, which is marked in red. So what are these perpetuating factors? There is this anxiety, there's poor sleep hygiene, there's a conditioning which comes in the perpetuating factor. And the predisposing factor is, of course, the personality, various coping mechanisms, age, sleep-wake cycle disorders, and precipitating factors can be situational, environmental, medical, psychiatric, and medications. And during COVID, we saw a lot of this, the precipitating factors. Now, it's not that each model, the cognitive, behavioral, etc., is independent of each other. What we like to believe that all these processes are acting in parallel rather than in isolation or isolated silos. It's very important that insomniac be given at least, for a good 45 minutes. So the consulting time for an insomniac is the same as what we have for a patient with dementia. Because for dementia, we have to give at least an hour. And so also for an insomniac, we have to give an hour. So you have to get into the history, pre-sleep conditions, the sleep-wake schedule. So basically, you have to ask each and every minute and hour of the day to the patient, nocturnal symptoms and daytime activities. Then you have to delve into comorbidities, and there are almost virtually all kind of comorbidities which can be associated with insomnia. So you really have to get down not just to the day to day or minute to minute or hour to hour functioning of the patient, whether it is pre-sleep or whether it's after awakening and during the work hours, but also you have to go into the medical history. So you really need to be a good physician, and a good physician can make a good insomnia doctor. You have to have a physical exam, because as told you, we don't do PhD in insomnia, but whenever the insomniac is not responding and you've forgotten to take the history of snoring, forgotten to take open the mouth and see the Malampati score, you would be surprised that many patients with OSA can come to us with insomnia. So really you need to do a physical examination of blood pressure as well as the neck circumference as well as the Malampati, etc. And of course, you need to do a cognitive scoring, because believe me, in sleep, this is my experience, if you do a cognitive scoring in your OSA patient, they are going to be convinced. because there is a decreased cognitive performance. So you may apply a brief scoring like MOCA or ACE, and they will show decreased performance in memory tests, execution, as well as planning. So you can pick up these cognitive deficits, and that's enough to scare them for a sleep study. So this is just to show you a patient who has an obstructive sleep apnea. As you can see, an effort is there with a flat line in the respiratory channels. And of course, correction of this will correct the insomnia. So really, this patient had a split night study with correction. So basically, OSA is another important cause of insomnia which is not responding to therapy. What are the tools and tests? Because the talk also involved diagnostics. Well, basically, you have to give them a sleep-wake diary, and this is freely available downloadable from the AASM website. And you have to ask them to, note in the sleep-wake diary for at least 2 weeks. You can give them an actigraphy. This is particularly useful when you are doing an intervention study. You have to apply insomnia questionnaires, and ESS will be dealt with by Dr. Ravi. But basically, the ISI has to be applied. And then sleep study only in those insomniacs which are not responding, or where you're suspecting OSA to be causing the insomnia, or you're suspecting associated parasomnia or narcolepsy disorder. Believe me, narcolepsy will also have insomnia. And you may need to do MSLT, particularly if you have a suspected excessive daytime somnolence due to narcolepsy. So ISI, it's a very easy tool. We can do it sitting here. Please rate the current severity of your insomnia. How satisfied or dissatisfied are you with your sleep pattern? To what extent do you consider your sleep problem to interfere with your daily functioning? How noticeable to others is your sleeping problem? How worried you are? And it's so easy to score. Most patients are able to do this. And anything above 15 indicates that you need to intervene in these patients. So the treatments are behavioral is the first line. You must have a good psychologist with you. We do a lot of Yog Nidra. We've published on that. There's a cognitive restructuring which needs to be done. And just to tell you that if you don't have the luxury of having a psychologist doing a CBT every week for 8 weeks, you can go ahead with Yog Nidra, which is, devised much before CBT came into play, and has been shown by my PhD, Dr. Karuna, to produce improvement in the stage 3 sleep as well as the total sleep time. Sleep hygiene, all of us are aware, many of us don't follow it ourselves, has to be followed. And of course, treatment, now we have the latest drugs. We tend to use a lot of DORAs now, which is the dual orexin receptor antagonist, which is Davigo, which is available in India. I virtually stopped using Zolpidem because of the next day effects. And the DORAs have had a trial with the next day performance in driving as well as falls and balance. So that way they are a bit superior to the Z drugs, though we don't have a head-to-head comparison. So the traditional is start with the behavioral and cognitive therapy, but give a short term of the drugs, pharmacotherapy, and then gradually, reduce the amount of pharmacotherapy. In that you can make it alternate day, or you can make it reduce half the dose or whatever, and then taper it off over a period of 6 to 8 weeks and sometimes 3 months. Coming to the second part of the talk, though my time's up, parasomnia, I think I'm just going to go to the last slide because the time is up and I'm standing between you and lunch. The non-REM parasomnias, the REM parasomnias, and other parasomnias. Now, why are these parasomnias important? Because the parasomnia is important for us because one is, of course, it's more seen in children, as was told by the previous speaker, but they may be masking underlying sleep disordered breathing. They may be masking underlying narcolepsy, and hence, if a parasomnia is very frequent and it is occurring out of situation and it is troubling the parent as well as the relative, their sleep study is warranted. So a parasomnia which is not responding to the conventional methods of cognitive behavioral therapy or pharmacotherapy needs a PSG study, and this should be carried out in a lab. So I think I will just go to the last slide because my time is up, and parasomnias by itself is a huge topic. I'm just going to tell you the differentials. So the differentials, of course, for a neurologist, I see a lot of parasomnias which are being treated as seizures. So there's an overdosing of anticonvulsants in parasomnics because somebody has made pavernus nocturnus focal seizure or a unilateral, PLM as a focal seizure, and a parasomnia who's having somnambulism as a seizure disorder. So really, you need to differentiate between seizures and non-REM parasomnias, where in non-REM parasomnias, they are very prolonged as compared to seizures, and generally you have one episode in the night. You do not have multiple episodes. Whereas in seizures, they are very brief. Within few seconds, they are over, and they are pretty stereotyped, and you have multiple. You may have as many as 15 to 30 episodes in the night. That doesn't happen in a parasomnia. And in a parasomnia, the eyes, especially sleepwalking, the eyes are kind of, open, and there is amnesia as compared to a focal seizure where the eyes may be deviated or uprolled. So that's how you differentiate it. But generally, this is a good algorithm to remember depending on the timing of the movement or the timing of the event which is happening. If the person is having sleep is a time of motor quiescence, but if the person is moving around before they are falling to sleep, then you should strongly suspect, RLS, which is causing a sleep onset insomnia. RLS is an important cause of sleep onset insomnia. And very often we ask them to bring a home video which confirms the diagnosis. And the treatment, of course, is pregabalin or gabapentin, and pramipexole, virtually diagnostic, very low dose of pramipexole relieves it. Whereas if the patient is going into the sleep and then jerking awake, then you have to think of a hypnic jerk. And all that is required reassurance. But if it's very recurrent, then we give a small dose of clonazepam. Whereas if it's occurring in the early night, within 60 minutes, within 90 minutes of falling asleep, and it's a very prolonged episode, it's a single episode occurring 3 months or 6 months apart, then you have to think of a non-REM parasomnia. Whereas if it's occurring in the latter part of sleep, then you have to think of a REM parasomnia or a RBD. Now in RBD, it's very essential that we follow up our patients because many of them, almost 60 to 70% of them, RBDs are harbinger of a neurodegenerative disorder like Parkinson's or MSA. So I'll conclude here, but if there are any questions, I can take them because I've left out the pharmacotherapy of parasomnias completely.